Welcome. My name is Steve Elias. I'm the director of the Center for Vein Disease at Englewood Hospital in Englewood, New Jersey. And we're here with Mark Garcia, who is the CEO of EndoVascular Consultants in Wilmington, Delaware, and also a very well-known individual in the management of deep venous disease. And we're at the VEITHsymposium 2019. And what we're going to talk about today is first perhaps a misnomer, and then how can we change that misnomer and how can we fix that misnomer. So Mark, I want to ask you about the words chronic DVT. Why is this still around?
That's a great question. As what Steve's alluding to is the fact that chronic venous occlusions actually are not related to DVT. They're just collagen matrix that occludes the vessel itself. And so the misnomer that you're talking about is using the word DVT. So we try to really use the word chronic venous occlusions to indicate what exactly we're working on here.
Right, and that's the kind of patients we're really talking about today in terms of, we're going to talk a little bit about the Access PTS trial that you've completed and submitted for publication. But first, give us an idea about the unrecognized patient who has chronic disease that is walking around, but nobody even thought about, A, did they have the problem, and B, can I help them?
Yeah. So the population that we're talking about, first of all, are patients that are suffering from post-thrombotic syndrome. So many people have heard of the ATTRACT trial that was published a couple years ago, which was really related to acute DVT. But some of the things that came out from that study, for example, is that people who have infrainguinal disease or disease that's below the groin level in the femoral popliteal segments, everyone has thought that really doesn't need to be treated, but in reality, that study showed that 44% of the population with just isolated femoral popliteal disease still goes on to develop post-thrombotic syndrome. And many physicians still across the globe, A, say that it doesn't need to be treated, and B, tell their patients that when they have chronic DVT or chronic veno-occlusive disease of the leg, there's nothing that can be done about it, and that they have to learn to live with it, take anticoagulants, elevate their leg, wear compression socks, and basically live a very miserable quality of life and decreased activity. And so years ago, we started to embark along this train of trying to show that this can actually be treated and treated well, safely and effectively, which led from some of our early studies to the trial called Access PTS. And that study, as you mentioned, was completed. We've submitted the data for publication and hopefully will be accepted soon so that we can get the word out that these patients absolutely don't have to suffer from post-thrombotic syndrome and that we can do something for them.
All right, so give our listeners, obviously patients had a previous history of DVT, you're going to think about working them up. What is your diagnostic algorithm in patients who have a swollen leg or have an ulcer, they've had a previous thrombus, a DVT? Where do you start with? I know you're going to start with ultrasound. We always start with ultrasound. But beyond ultrasound, where do you go next?
So if the story and the physical exam suggest anything more than just below groin disease, which is where ultrasound is very good at identifying, if we think that there's something more central, again, that's really based on physical exam and listening to the patient, then we may do central imaging with either MR or a CAT scan to identify where that blockage may stop. And as I try to explain, it's very, very important to understand the anatomy and to know where this chronic blockage starts and where it ends, so that it gives us a good game plan as to where we're going to attack this, whether we come from the ankle or from the knee, or can we even come from the groin if it's just a central blockage whatsoever. So that's really the first part of it, is identifying the anatomy and knowing where we're going to attack this.
All right, now in the Access PTS trial, what percentage of patients had just infrainguinal disease, just superinguinal disease, and what had a combination?
So no patients had just isolated suprainguinal or iliac disease, because we know that those patients really wouldn't undergo lytic therapy. We would just cross that lesion and stent that open, which people do very well with that. So everybody had to have had at least femoral disease, could be fempop, and 2/3 of the population were isolated fempop. and then 1/3 had iliac disease in combination to infrainguinal disease.
All right, and walk us through a little bit. You identified the patient, you want to treat them. Give us, a brief outline about access, what you did, and then post-treatment.
Okay, so first and foremost, as I said, is identifying patients who are suffering. There's always the risk-benefit ratio we as physicians have to determine before somebody would undergo any procedure whatsoever. So we have to make sure that patient A is worth having those risks that could come from the procedure. Although very rare, they still are there. And so that's the first thing, identifying the correct population. Once the patient has been determined to be a good candidate for the procedure, we understand the anatomy. We want to start at the lowest point of a normal vessel. So we want to start below the blockage level so that when we're done, we are creating direct inline flow from the ankle back to the heart. That's really the key, and I think one of the reasons why our results have been so good. The access is obtained. We basically use CTO sort of techniques like we do in the arterial system to cross the blockage. We create some working space by balloon angioplasty to an expected size of a vessel where that blockage is. And then we put the EKOS catheter in and infuse overnight somewhere between 0.5 to 1 milligram an hour.
And 1 milligram an hour of tPA.
Of tPA, correct. And then the following day come back for a follow-up. And if there is not inflow and outflow at that point in time, we really just usually touch up with further balloon angioplasty. And if a central lesion is identified, we stent. And usually at the end of that case, we've restored flow at that point. When they go home on enoxaparin, typically for 30 days. We found that that's the best anticoagulant in the early setting, and then transition them to an oral anticoagulant. They all go home with the rules of the ABCs. The mnemonic is for activity, blood thinner, and compression. We want them to wear at least 20 to 30 millimeter knee-high socks every day from the time they get out of bed to when they go to bed. We ask them to start a walking program and increase their activity, keep that blood and that calf pump moving. And then lastly is the anticoagulant regimen, which is very key to keeping these veins open.
Now, just finally, do you see this and the Access PTS? I mean, apparently we had very good results, and we'll await the final publication. But a significant amount of patients improved, at least 2/3, according to lectures that you've given and stuff. Do you see this also as a way of getting better inflow for patients who have superinguinal disease? Not just treating the isolated infrainguinal, but you see expanding this patients who also, people say, oh, there's difficult inflow.
Right.
Should we now be more liberal to help the inflow?
Yeah, the question really is does femoral and profunda inflow improve the patency rates of iliofemoral disease? I think is what you're really getting to, the stenting of that. And I think it does. I mean, I think it makes sense as a plumber that the more inflow you have, the better rate of patency you're going to see in that stented region. As you mentioned, the data, what I can share with you is that we met the primary endpoint. We were looking for a 50% population that had at least a 4-point improvement in Volata. 67% of the population actually had that 4-point improvement in Volata. And every metric that we used to measure for this study, we used Volata, we used VCSS scoring, we used veins quality of life and SF36 PCS. Every single one of those were statistically significant by far in improvement. So we really nailed this. We hit it out of the ballpark, as they would say. And when you look at the patency rates, we're greater than 90% in every segment we looked at 1 year. All these metrics were taken out 1 year from the treatment center. So it's great news for this population.
Yeah, and I think that is the takeaway here. Just when you thought, hey, there's nothing we can do, there's really a lot we can do. And this is the beginning of probably better stuff that we can do as we learn more and more about this chronic disease and helping.
Absolutely.
So thank you for being here.
Yeah, thank you, Steve.
And we thank everybody for listening.
Thank you.